The Black Doctors podcast highlights the stories of minority professionals with the goal of inspiring others. Season 2 provides more episodes and features a wider variety of professions. If you like what you hear, please subscribe and share with others, because the next generation can't be what they don't see. Tune in every Monday to hear our stories told by us.
Hello and welcome back to the Black Doctors podcast. Today I'm privileged to be speaking with Dr. Beti. She is an anesthesiologist who is currently practicing in California. Thank you so much for joining us and welcome to the show.
Thank you for having me. I'm really excited to be here.
I'm so excited to hear your story because I know you have an amazing, incredible story to tell. So if you want to just go ahead and tell us about yourself and how you came to be who you are and where you are.
Sure. So, I will start from where I'm from. I'm from Ethiopia. I was born and raised in Ethiopia, and I moved to the United States when I was 16. And my entire family moved from the capital city of Ethiopia, which is Addis Ababa, to Los Angeles. And so that happened. It was a big cultural shock, obviously, like you can imagine, and it required a lot of adjustment. When I got to LA, I came from a French system, so I speak French, and I've learned it since I was 2 or 3 years old, and I grew up in a French system in Ethiopia. So when I came to this country, my English was terrible, even though my writing was fine. I've always been good in academics, especially in STEM, and so that was okay. But I struggled a lot to kind of communicate, adjust, and get into high school. And so I started high school, and I did 2 years of high school. And after that, my high school experience was probably not the best. I wanted to kind of do what I need to do to get to college and then just kind of, peace out. And so I did that, and I went to UCLA. I was very grateful to get into UCLA. Once I entered UCLA, I did 3 years of French, undergrad. That was my major. I was a pre-med since the first day of going into college. I always wanted to do medicine, and I knew I was going to become a doctor. And so I did 3 years of undergrad, and then I took a gap year because I wasn't sure exactly if I wanted to go straight to medical school or kind of wait and do a post-bac, because I was a French major and I didn't think my application was strong enough to just go straight to medical school. Yeah. So I ended up enrolling in a post-bac program. And then after a week, dropped out because I didn't think it was the best match for me, and enrolled within the same month into a master's program. So I ended up doing a master's in pharmacology. So I did 2 years of that, and then applied to medical school. I did my training in medical school in Virginia. I went to UVA, University of Virginia in Charlottesville. Okay. Yeah, after grad school, and then I was really tired of the East Coast. My entire family was in California, so I kind of wanted to come back to California. So I did my intern year in San Diego at UCSD, which was mostly internal medicine. We had that. I don't know if they still have it now, but we had a 1 year of something else, of transitional year or internal medicine or surgery. So I chose internal medicine for my first year. Mm-hmm. I did that in San Diego, and then I did my residency at UC Davis, finished that, and then decided to do a fellowship in global health and equity in anesthesia, which is a pretty new fellowship at UCSF. I applied for that fellowship very last minute because I saw it on one of our anesthesia newsletter, the AS Monitor. Mm-hmm. Yeah, so it was published on there, and I saw it I think March or April of that year, and they were interviewing candidates, and I quickly emailed the program director and I said, hey, I really want to do global health. In medical school and in residency, I've done some trips back and forth in Africa in terms of global health work. And so that was my true passion lies in that. And so I emailed them and I was like, what do I need to do? I really want to hear more about this and possibly apply. And then they got back to me right away. I applied, I interviewed, and then I got in. It was just, everything happened in 2 weeks. Yeah, it was crazy.
It's meant to be.
It was meant to be. And, I moved to San Francisco and I started the program. And it ended up being just an awesome program. I can't say enough about the program. It's just great. It gave me like enough independence for me to like, like straight out of residency, you still are new, you still are kind of like, like making sure your skills are good enough and you're still like, like adapting in a way for an attending role. And so when I went to my fellowship, it was great because I worked as an attending half the time. I would say, like 20 hours a week or so, 20 to 25 hours a week. And then the rest of the time I worked on my fellowship project. So it was just great. So I would just go and, do my attending stuff and then do my fellowship stuff. It was just great. And, I got to go to like East Africa for some projects, which was great. I also worked on some equity projects, so I can go into it later. It was a great eye-opening experience, like fellowship, and I just finished that. So now I'm taking a few weeks off to kind of reset and just relax, and then I'll be going to private practice mostly. So I'll be working, in a hospital in a private practice setting and not academic. I'll still be doing a little bit of academia on the side, but my main scope of practice would just be like, private practice anesthesia. Yeah.
Amazing. I hope you're enjoying your well-deserved break.
I am. I'm like picking up all kind of hobbies.
So as you're moving forward, starting your official career as an attending, what type of practice did you join? And then what did you kind of look for as you were looking to work with the private practice group versus academia versus the other options that are out there?
Yeah, that's a good question. So I'll be joining Kaiser. I'm sure like a lot of people have heard of Kaiser. It's a big hospital system here in California. And I think they're in some, maybe a few states outside of California.
Oh, yeah.
The main things I was looking for, this was a big debate for me. I was like, should I stay in academics because I want to do global health and I do like academia, or should I, like do private practice and kind of steer away from hardcore like academic practice? And for me, the decision was based on a lot of different things. First thing for me was if I stayed in academics, it would be UCSF, and like just life in San Francisco is extremely expensive. And so for me, I was just like, do I really want to stay in an extremely expensive city for what? Like, I didn't have any great answer, other than like continuing to work on my projects, which I can do while still doing private practice. That was one of the biggest things. The second thing is, I think all comes down to like your quality of life as well. Like, do I want to continue doing research and be a PI, teach residents and kind of stay in that environment? Or am I looking more for a job where I show up in the morning, take care of my patients, usually, work with CRNAs or whatnot, and then kind of go home and maybe do a few things on the side. I have a lot of other like ambitions outside of medicine as well, or other things that I'm doing outside of medicine. So I needed the time, I needed that extra time of me like not working on a bunch of projects so I can work on my own personal projects, So it was a combination of many different like factors. I am very grateful now that I can do both in a way. I'm still going to be working in the hospital, and I mostly work with CRNAs, and I do my own cases once in a while. And then the rest of the time, I would also be like teaching. It was mostly of a teaching mentorship role to residents at UCSF. So it ends up being like a pretty good deal.
Cool. Yeah, sounds like the best of both worlds.
Yeah.
And when you're shopping through different groups and looking around, they kind of advertise what type of anesthesia they practice. So they'll say, some peds, no peds, OB. What type of anesthesia will you be doing?
Yeah, I'll mostly be doing general anesthesia and then OB anesthesia. Those are the main things. I do like regional anesthesia where we do blocks and things like that for like my cases. And that's pretty much it. I do not do any ICU cases, but we do go up to the ICU and sometimes intubate or place lines if they asked us to, which I've done before. But it's mostly going to be general anesthesia, OB. I don't do any peds. I would not be doing any cardiothoracic or cardiovascular anesthesia. So it'll be OB and general anesthesia. Most of it will be that.
Yeah, that's so cool. It's definitely so much flexibility in the
Yeah.
field.
Yeah.
So at what point did you decide to become a doctor? It sounds like you decided at a very young age or early on.
Yeah, I honestly don't remember like a specific like instance. I've always almost wanted to become a doctor since I was maybe 10 or so. I loved science. I loved anatomy since I was like very young. Just always fascinated me. And so that was always, it's always been in the back of my mind. And then through time, I had a few like family illnesses. I got sick at some point myself, and I had surgery. All those like things compounded to me being like, hey, I think I really want to do this and be on the other side, for once, and see how it is and how to take care of patients and kind of give back in a way.
So at UCLA, you were pre-med, and then how was your time at UVA?
It was fine. It was great. UVA was a good 4 years. I was involved in a few different things. As we're applying for residency, like there's like as you know, a few things that we have to like do and kind of make sure like our resume looks good when we're applying. So I ended up doing research. I've always done research a lot, even in undergrad and like grad school. I had like a research thesis and stuff. So I ended up doing pretty cool research in anesthesia at UVA, where we were testing this new like steroid-based anesthetic on rats. So that was cool. Yeah, and so we did that, and it just got published, so that's cool. And then what did I else? I also did like a lot of recruitment efforts. I was really involved with SNMA, and I was like leading a recruitment for I think 2 years or so, where we like heavily recruited minorities into the program. That was pretty cool. I that was one thing I actually do remember very vividly. It's just like really trying our best recruiting and retaining medical students, and it did work. I mean, there's so much more minorities in the program now. I remember when I graduated from UVA. I went back and I was just looking through pictures, and I'm like, oh my goodness, there's so much more like minorities in the program. That was crazy.
Oh, wow.
Yeah, and it just tells you like your efforts are not always, the efforts that you make today, you might not see the fruit of it like right away, but it will like slowly catch up. So I did a lot of SNME related stuff. What else did I do? Yeah, those are the main things. UVA was a great school. I would recommend it to anyone. I felt like when I came out to the West Coast, my training was very strong. I felt like I learned a lot of stuff. I had like good ethics in a way, like work ethics overall, and it was a great training program. And maybe it was because they always say like the East Coast and the West Coast
Yeah.
training is different, And so I don't know if it's because of that, but I remember coming to California, and I was like everyone is so chill here.
Adjustment.
Yeah, and so it was a great program. Yeah.
And then why did you choose anesthesiology?
That's a very good question. So when I was 16, I had like major surgery. I had like a very rare condition called, I'm sure you know it, but for those who are listening and don't know what it is, it's called pheochromocytoma. And you learn it in like med school as like a very rare like endocrine condition that a very small percentage of the population gets it. And so I ended up getting that. And so when I was scheduled for my surgery and I was going in, I vividly remember the surgeon saying, like the surgery is very complicated, and you surviving pretty much relies on many different people in the OR, especially your anesthesiologist. You should meet them because they have to tightly control your blood pressure, otherwise you can have a stroke. And all I remember is my family saying, "Where's the anesthesiologist?" And so that was like my very first introduction to anesthesia. I was like, who's this person who's like in the background and doing magic that no one like knows?
Right.
And so that was like the first time I was like, oh yeah, I'm going to kind of consider anesthesia. And then when I did when I went to grad school and did pharmacology, which is very much, I think anesthesia and pharmacology is very related. And so I loved pharmacology. I loved it. It was great. I loved everything about like the whole, my grad school, like, program, which is pharm and anatomy and physiology. And so I was just like, you know what, I think I want to do anesthesia. And then when I went to medical school, I already had that in the back of my mind. So I ended up kind of shadowing very early on, like end of first year. I was in the OR kind of shadowing, and I was like, I really like this. It was, the mix of procedures, the fact that there's no rounding. I like the fact that, I do like continuity of care, but not to the point of like me being like a family medicine physician,
Right.
I do appreciate what they do, but for me, I'm more like a very like instant kind of person, like when I give a medication, I kind of want to see what it does right away. I can't, I don't like waiting 3 months seeing if this medication works. you know, I like the procedural aspect of it too. I'm very much hands-on. It was great. Everything fit. And I was like, I love this field. And it ended up being good. I love anesthesia right now.
Yeah, anesthesia is such an incredible field. I mean, I'm a little biased, which is why I jumped at the opportunity to bring you on the show. I think everybody should go into anesthesiology.
Yeah, I agree.
And then once you finish your residency training, though, you told us how you applied to this fellowship and in very short order were accepted and started. Tell us more about this amazing fellowship that you're able to participate in.
Yeah, sure. So it's pretty new. I think it's only maybe 4 years old or so. All the fellows who graduated have stayed in that department. So it's kind of cool to see like who the first fellow was, who was the second one, the third one. And so it's basically all the fellows are anesthesia trained. So you have to do your anesthesia residency to apply because it's all geared towards anesthesia. And the main idea is looking at education, capacity building, anything kind of related to anesthesia on a global scale. So our group has a lot of work with Uganda. So they have partners in Uganda who are anesthesiologists that they have long-term projects with, which include capacity building, research, and things like that, education. They also have a lot of partners in Tanzania. So I was in Tanzania for about a month, like teaching anesthesia to local anesthesia providers and like giving them a like a CME, a continuing medical education type of course where we're like reviewing key concepts for like general anesthesia, and we also did pediatric anesthesia as well. And so it's geared towards mostly, I would say, capacity building and making anesthesia safe worldwide. However, whatever that means, if it's either through education or trying to understand why there's no anesthesia facilities, why there's no anesthesiologists or anesthetists in some countries, why is there such a shortage of medications, So it's just kind of looking at those dynamics. So that's one part of the project. The other part is equity work. So equity work globally, obviously, that's kind of like what global health is in itself, like equity in a way where you're trying to analyze why do some people don't have like, adequate medical care or like safe medical care or timely medical care. And also locally. So looking at equity locally. So some of the project that my colleagues were working on was creating a consent translation video for patients who don't speak English, because oftentimes, we usually have an interpreter phone, but it's, they were doing a trial of just videotaping the consent and having someone on video explaining everything. So that by the time you come and consent them, they have an idea what's going on. They don't have as many questions too, And so that was one project they did. A recent project I was really involved in was creating a health equity curriculum for anesthesia residents and surgery residents. So this was started June of this year. It actually came from just kind of the idea of like, how do we make sure residents, like physicians in general, have a good sense of health equity as they finish their training, because a lot of this is not embedded in our medical education, it's not embedded in our residency education,
right.
But somehow we're supposed to be aware of these things, and it's like information that you kind of gather through your own process of just researching.
How would you define health equity?
I would say health equity is, there's health equality and then there's health equity. Equality is everyone has the same care. Equity is access to care, safe care, based on certain predisposing factors. Sometimes, so I'll give you an example because I don't know if my definition makes sense. Equity would be, looking at, for instance, immigrants, how do immigrants get access to care with them being immigrants? For example, it would be, why do immigrants don't have, safe care? What's the reason for that? Is it because they don't have access to care? Is it because of the immigration status? And just like recognizing that just being an immigrant can give you unequal care in general. I don't know if that makes sense. Or being, an African American person, or a minority, or being a certain kind of like, a certain,
socioeconomic status.
Yeah, socioeconomic status. So I would say health equity is access to care that's safe, that's timely, that's in a way fair, regardless of your background. You know what I mean? Regardless of what you come from, regardless of your racial background, your gender, regardless of your immigration status. You know what I mean? So That's how I would define it. I don't know if this is like the textbook definition, but that's kind of like the idea is, how do we make sure even physicians graduating, residents graduating, have that knowledge, that basic knowledge that, how do we make sure the patients that we see who come from many different backgrounds and many different statuses get the same care no matter what, and understanding why there's a difference in care and where everyone is starting, and why someone is at this level, versus another person who's at a different level, and what caused that disparity in healthcare, or health status in general.
Yeah, no, that's huge and so important and timely, something that we should have been focused on a long time ago. How did you incorporate that into a curriculum for the residents?
Yeah, so for the curriculum, we basically came up with like core topics that we want them to be exposed to in terms of health equity topics. And it's a very intro level course, like curriculum. So we wanted it to be not too overwhelming, because there's a lot of stuff that we can be teaching, but it's just like the bare minimum, or the basic things that most people should know, just kind of like coming out of residency and training. So we divided it into lectures and small group discussions. So the lectures cover, like, one of the topic is like health disparities and social determinants of health. The second topic is cultural competence and structural competence. The other one would be structural racism and how to be an anti-racist. So there's like different topics. I think we had four topics. And then the last one was a health equity journal club. And the journal club, that was designed not only to target residents, but to also target faculty in general. Because there's not anything that targets faculty or staff in general, in terms of like, how do we make sure we address health equity every day in our work, like, do we talk about it? When do we talk about it? So that was mostly created to make sure the staff and faculty also has something, like some kind of a platform or discussion about these topics that's continuous, And so that got launched right before I left, and it was great. It went really well. And then the last component of the health equity curriculum is community engagement, where we are trying to expose surgery and anesthesia residents to community-led organizations, so that they are able to volunteer, work with them, start projects, whatever that inspires them to do. So just so they have that pipeline open, so they can do that if they want to. So that's the last part. Yeah.
Wow. That's a lot.
Yeah. I mean, it wasn't an easy project, I'm going to be honest. And it's still, by the time I left, the content part was done, almost like 100% done, but the implementation phase has not been started. So the fellow after me is kind of like starting the implementation phase, which will take a lot of work too, And so, but I mean, I think it's not only timely, but it's like so necessary, Like, I haven't had any kind of equity teaching whatsoever in residency or medical school. So I think there's like that thirst to just kind of learn from everyone. I think everyone is open to learn and interested in learning. So we're just kind of using that opportunity to be like, okay, this is the time to actually push this through,
Yeah, it's so cool. And for you, Dr. Beti, how does your faith, your heritage, your culture influence how you practice medicine?
Yeah, I mean, that's a good question. I'll start with my faith first. I'm Christian. I'm a born again Christian, and I feel like in the last year and a half or so, I've become very much close to my faith and really meditating on the Bible and things like that. And I think for any faith is I mean, I'm going to quote the Bible because that's what the Bible says. Faith is nothing without works. So for me, it's you can't just have faith without really showing your faith and showing it with your own work. And so for me, when I take care of patients, I take care of anyone who comes through the door the same, and I try to treat everyone the same, no matter who they are, where they're from, and I think that should be as physicians, that should be us at all times, regardless of who our patients are, who we're taking care of, But that's not always what happens, We all know that, when you have a celebrity who comes into your hospital or someone who's very famous or someone who's donated a lot of money to the hospital, you get a special FYI email or note saying, hey, just so you know, this is who so and so. And you're like, well, now you're making me anxious. I'm like, I'm not going to do anything differently, but now I'm like more anxious than I should be, And so my motto is like, just, do your best at all times, do your best and treat everyone the same. And patients always come first. No matter what, like even with surgeons and, like dealing with kind of like canceling cases or going forward with cases and like kind of deciding what's next for a patient's care. I think I always have to kind of remind myself and go back to the basics of like patients come first, like patient safety comes first. If this is not safe for the patient, we're not going to do it, And so, so that's kind of like how I use my faith. In terms of my cultural background, I have an accent, and so a lot of my patients ask me where I'm from, and that always kind of sparks the conversation. And I think when I have minority patients, that makes them feel comfortable sometimes because they feel like, oh, okay, someone who's different, who possibly looks like me, or has this kind of similar background, and that kind of helps, I think, kind of anchor my relationships with patients when I meet them for like 10 minutes in the morning, So it's always good to like, for me, I always find it, I almost find it like a privilege in a way to kind of be like, okay, to be able to connect to my patients to that level, And so that's kind of how I use my culture. There've been many times where I like translated in my language, my native language, or like I speak French. So like I've definitely had patients who are very happy to hear that I speak French, and so made them feel very comfortable. Actually, now speaking of that, I just remembered a patient I had like a few months ago. It was she's probably like in her mid-20s, was coming for an embolism coiling in the neuro IR. She had a hemorrhage, but she was still pretty intact and talking. It's like a small bleed and they're trying to embolize it. And, where she was just, she's young, and with COVID, she couldn't have any of her family members in with her, so she's like obviously scared and upset and like unhappy. And then we just kind of started a conversation. And then through just like a random conversation, found out that she speaks French and she's from Haiti. And so, wow. And it completely changed the dynamic. She was like, oh my gosh, I'm so happy. It's just like we connected. She was so happy. And then afterwards, I went up to the ICU. By then, they allowed her mom to come in. I met her mom. And then her mom ended up knowing the surgeon. And then I met the surgeon. It's just like, everyone's like, oh my gosh, we need to get your number. I'm like, yeah, I can't give you my number. So it kind of, I don't know, it helps to kind of like find ways to connect with patients,
Yeah. Oh, it's so amazing. So as an anesthesiologist, you were on the front lines of this COVID pandemic. What was your experience?
So when COVID hit, for us, it was like, March is when we felt like we saw the surge, in the patients that were testing positive. So at that point, we stopped doing a lot of the elective surgeries, like a lot of hospitals, for many reasons, because, we didn't know at what scale the surge was going to be, if our hospital was going to be overwhelmed. So we were immediately, I think, as soon as we had a surge, everyone had a role in a way in terms of kind of like redesigning like our roles again, because we're not doing cases anymore. So a lot of us had a free time, but all of our free time was taking it was taken with redesigning workflow systems and protocols and things like that for COVID patients. So a lot of us were working on like creating space for ventilated patients. So there's a whole team who was, creating teams like team A, B, and C, who comes in at what time, who takes care of patients, how do we make sure that team, if they're exposed, don't expose other people and other patients. There's like a whole, dynamic with that. Creating actual physical space for patients in case there was like a huge surge that we couldn't control, and creating, areas where patients could go and stay ventilated. I was in charge of creating a COVID operating room so that when patients who are COVID positives come into the operating room, what would be the protocol? And then redesigning the entire operating room. That took a lot of efforts as well. I was also part of the team leading the COVID acute response team for the hospital. So we created a team of anesthesiologists who would be called for COVID positive patients intubation and for placing lines. So our department volunteered to create a team to just handle that because the ICU was getting overwhelmed. Wow. And so whenever they had a COVID positive patient, they will call us. It will usually be one attending in a CRNA is how it started. And then it ended up being attending in a residence as, the protocols got reviewed and like redefined. But you get called, you go and see the patient and kind of get a history. And obviously we have all of our gear and protection with us. We have a PAPR and our gowns and gloves and things like that. And so the fact that we had a team that did this over and over again made it much easier, I think, in my eyes to kind of make sure you don't get contaminated, you don't contaminate other people. Like the flow was much better versus just having kind of like random people just come in one day and intubate and then the next day intubate. So we try to do it in lumps. So, if I was on, I'll be on for 3 days and then I'll be off for like a whole week and a half or so, just so I can also kind of monitor myself for symptoms and I can kind of get a break as well. It's also mentally very draining. You're like my first COVID intubation, I was very nervous. Like I've intubated patients many times, but I'm just like, oh my goodness, like I have to make sure, as like we have to intubate them right away. We don't like ventilate them beforehand and things like that. So you have to intubate them right away. And if you don't, then you have to ventilate them. And then you have to ventilate them. And you're exposing everyone to aerosols and the virus potentially, And oftentimes they desaturate so fast that even if you do ventilate them, they might still just kind of be at a very low oxygenation. And so that was very scary. And so, it was very mentally draining, I think. And I don't think I realized that until now, because when I was doing it, I felt fine. But now I'm looking back, I'm like, man, that was very stressful.
Yeah.
And so I think I'm sure it's the same for every physician. I mean, everything is stressful, especially for anesthesia, because our procedures that we perform are very much high risk procedures, when we intubate a patient, extubate a patient, and so I think for us, like the precaution that we have to take is a lot more compared to like maybe like an internal medicine physician who just comes in, talks to the patient and leaves the room, versus us who are standing there intubating, in the OR, suctioning, you just don't know. There are times you have to suction a COVID patient because if you can't ventilate them, you got to make sure there's no plug, And so it was very, I would say, mentally definitely draining, but, it helps to work with a team of people who are like supportive. So everyone's very supportive. And if anyone said, hey, I can't do this today, someone else will step in, which was really nice. So, yeah.
Well, I'm sure that the folks in San Francisco, appreciate you as well and the rest of your team there.
It was my pleasure. I mean, everyone, I don't think it's just me, but everyone kind of chipped in and it was like a whole team effort. Yeah, for sure.
I think throughout your story and throughout your life, there's this theme of increasing diversity wherever you go, increasing equity in healthcare. I think one of the most recent examples is your work with the American Society of Anesthesiologists and this mentorship program that you formed. Can you tell us about that?
So I created a mentorship program last year, and it was a very simple program where I decided to kind of match underrepresented pre-medical students to underrepresented medicine, like mentors, physicians. And so the idea stemmed from, from social media, because people were texting me and DMing me and saying, hey, like, can you like review my personal statement? Like, I have like this is my GPA. Do you think I can get into medical school? So there's like a lot of requests, to the point where I was like, I think they will benefit from like a continued mentorship from physicians,
Mm-hmm.
And so that was kind of how the idea started. I took 7 students from social media. I made an application and have them apply, just so I can kind of figure out if they'll be appropriate for the mentorship, in terms of like when they're going to go to medical school, if they're taking their prereq classes already, if they're studying for the MCAT already or not, what their plans are, to kind of assess if they will benefit from the mentorship. And then I had them match with 7 mentors who are all underrepresented in medicine physicians. And so they started the mentorship in November, and it just ended like a month and a half ago. And the premise is all virtually done. So we started in November. This was pre-COVID, and I felt like even pre-COVID, I was like, it's really hard for people to make time and meet in person. So let's just make this on Zoom or WhatsApp or whatever platform they decide to choose. And it's in this 1 hour a month is the commitment. It's just 1 hour a month where you're supposed to meet with your mentor and have an agenda. So I usually give them like a small plan of what they should be covering and give them like guidance, but really is up to the mentor and the mentee to kind of discuss on some things. There are definitely things that I would encourage them to review, such as like personal statements, letter of recommendations, MCAT studying strategies, and things like that. Like research. Mm-hmm. So there's like a list of things that I usually kind of like help. That kind of helps them guide the conversation with their mentors, but in general, it's kind of like a free form mentorship. And then at the end, so it was like about an 8-month program. At the end, that they're done. And so when they're done, it doesn't mean they all get to medical school. Obviously, they're all at different stages of their application, but they get what they need for that time being. So for some, it might just be, hey, I just really need help, like getting motivated, and like I'm really like someone telling me that I can do this. That might just be the mentorship. Even though we don't want it to just be that, but that might just be what a mentee takes away. Mm-hmm. For some, it might just be, I needed help with my personal statement and I got that. Or it might be, I needed guidance on some things and I got that. So the first cycle is done. The second cycle is about to start. And I just got a grant from the ASA, which I'm very happy about. And so I'll be doing the same thing. I'll be changing a few things based on that first cycle feedback and making it a bit more targeted mentorship. But that's kind of the idea. And eventually I do want this to be kind of like train the trainers course. So for in global health, a lot of the courses that we give, we wanted to kind of grow and we want people to be self-sustainable. So once we train someone, like let's say we train a group of 20, we try to find maybe 5 or 6 people from that group of 20 who will be able to train others, So we train them so they can train others. So my goal is to do the same thing with this mentorship, is to pick a few of those mentees, and then once they get to medical school, so pick them so they can be mentors for others and they can train others, and then continue that cascade of events. So we're not always the one training. At some point you just have to enable people to just do it on their own. And so that's kind of the idea. And I would like it to be kind of run. I would ideally want it to be run by mentees. Honestly, I would love this to be kind of run by mentees, and we are like kind of a guest and we're invited to their talks and invited to share ideas. So we'll see how it goes. But that's kind of the idea. I'm looking for mentors. I'm always looking for mentors. I think I have a few mentees already. I think there's more mentees than mentors, honestly. So it's never really hard to find mentees, and finding the mentors who are dedicated, that's kind of the hardest thing. So it's just 1 hour a week. I mean, it's 1 hour a month, and so it's not a lot of time, and it makes a huge difference in the the medical journey of a lot of the pre-med students. Like just last week, I did a mock interview with one, and she's doing really well. She's really happy. Her interview went well. I just had yesterday, I had a session with one of the mentees. She was not my mentee, but she's one of the mentees from the program, and she just wanted to talk about just like medicine and life in general, because she's really concerned that if she can't even do it, if she and it's just giving them guidance. It's just helpful, and just she was asking just like real questions. Like how many do you think, I don't know if I'm going to have a lot of loans, or, she's a female and she wanted to get married. So she's like, do you think I can get married on, And so they had like just real questions that they just, and it's important. And they don't get that because they don't have like brothers or sisters or parents who are physicians or in the medical field. So they have no idea, And so that's how I was. That's why I was like, especially being an immigrant, it's so hard because you're so preoccupied with so much stuff in your life. You're like, okay, my family needs to get health insurance. It's like, you're busy with that, let alone like other things in like being as a pre-med, or you're like, oh, I need to like find a job, or, oh, I need to like buy a car. Like, you're just like so busy with like the everyday hustle that you don't even have the time to reach out to mentors. And you don't even know if you have, it's hard to find mentors. So I'm hoping with this program, this will be an easy access for students to like physicians, like who've gone through it, who've done it, and they can get like real answers from physicians. That's kind of my goal.
Thank you so much for joining us. Anything else that you'd like to share with our listeners?
Thank you for, inviting me, and, feel free to reach out to me on my Instagram and DM me. I will put an email now on my profile just for any mentorship related questions, but I usually respond to DMs. Not that I need all my DMs flooded, but you know what I mean? Like, if you have a burning question about mentorship or being a pre-med, I'm more than happy to answer your question.
Thank you so much.
Thank you for having me. Yeah, thank you.
The Black Doctors Podcast is a nonprofit, volunteer passion project with the goal of inspiring all who listen. Tune in next week for another episode of the Black Doctors Podcast with Dr. Stephen Bradley, your friendly neighborhood anesthesiologist.